Good evening, ladies and gentlemen. Grüezi from Volkertswil, from the live stream studio. In the name of Medilas and our co-sponsors TierLab and TH Pharma, we would like to welcome you all to this webinar with the title Innovative Patient Care in Your Practice. The webinar language will be in English, since you have a lot of participants across Europe. Welcome to all of you. Due to the circumstances we had to change our original plans, meeting you all in a lovely rooftop bar in the city of Bern. However, we hope you are all well and you will enjoy the two exciting lectures and discussions in this online form anyway. We are extremely happy and thankful that we have gained for this evening two experts in the eye surgery who will give us deep insights from their experience with innovative patient care. It is a pleasure to introduce to you the first speaker, Dr. Erik Mertens. He is both physician and CEO. He is also president of the American Europe Congress of Ophthalmic Surgery Europe since 2019 until now, and he is medical director and eye surgeon at Mediopolis Clinic in Antwerp, Belgium. Erik will share his thoughts and experience when considering a premium IOL to look also at the surface of the eye with his lecture with the title, What is included in an ocular surface disease workup for premium IOL surgery patients and how to explain this to the patient. After the lecture of Dr. Mertens, Erik will answer your questions and will spend some time to discuss with you. After the discussions, we will move then to the presentation of the Dr. Kristof Vandekerckhove. We are very thankful that Kristof can be with us tonight. Also, he has to be in isolation due to a COVID infection. We all wish Kristof a fast recovery and are happy that he is with us anyway, sharing his experience with us. Dr. Kristof Vandekerckhove is chairman and medical director of the Vista Alpina Eye Clinic located in the canton of Wallis, Switzerland. He is a member of the Swiss Society of Ophthalmology and also the president of the Swiss Society of Ophthalmology Tariff Commission. Kristof performs close to 2,000 cataract surgeries a year and has extensive know-how on many implants. He will share with us his experience with the ISOPURE lens in the last 18 to 22 months. The title of his lecture is Replacing My Monofocal IOL Over the Last 18 Months. We would like to thank both of the lecturers for their valuable contribution to this webinar. Additionally, we would like to thank our co-partners TH Pharma and TierLab supporting us with the organization of this event. Without their support, such an event would not have been possible. Some organizational points at the end for this webinar. You all will be muted during the lecture, but if you would like to ask questions to the presenters or to the audience, you could raise your hand by clicking on the Teams hand icon on top of your Teams frame, and you will be unmuted then by us. Or you could write your questions or remarks using the chat function left beside the raise hand icon. Now, we wish you all an interesting webinar with exciting news on your eye practice, and we pass now the micro to Erik. Please, Erik, thank you.
Thank you, Daniel, for this very kind introduction. I would like to thank Medlas and TierLab for inviting me to give this lecture. So, if someone can bring up my presentation, then we can start with my talk. Thank you. So, why diagnosing dry eye disease matters to successful IOL surgery. Next slide, please, because I cannot control my slides from here. So this is my financial disclosure, and my name is Dr. Erik Mertens. I practice at Mediopolis, Belgium, and my specific area of interest is cataract and refractive surgery, in particular multifocal IOLs. And as a result, I'm very aware of the importance of ocular surface health and the role it plays in optimizing outcomes for my cataract and refractive patients. So there might be more patients than you realize suffering from dry eye disease, and it's often mis- or underdiagnosed. In fact, different studies have confirmed that about 80% of cataract patients show at least one sign of ocular surface disease. The reason why ocular surface and dry eye disease is frequently mis- or underdiagnosed is because it is so complex, and professionals don't always understand the far-reaching consequences. Some of the reasons why diagnosis is challenging are symptoms are often the triggers for deeper investigation, yet more than half of the patients don't report any symptoms relating to dry eye disease. There are symptoms like fluctuating vision that are not normally associated with dry eye disease, resulting in these patients being overlooked for DED. To make matters worse, traditional signs like staining and symptoms don't correlate, making diagnosis even more complex. And in addition, these signs and symptoms fluctuate and vary, and dry eye disease is a disease of variability. The ocular surface disease subsets symptoms overlap. For example, patients can have both dry eye and meibomian gland dysfunction symptoms at the same time. The impact of dry eye disease can be very severe, and it is deemed as a contraindication for surgery if it is not managed effectively and controlled. So it can lead to inaccurate pre-surgical measurements, to IOL calculation errors, and refractive surprises as well. It reduces vision quality, and impaired surgical outcomes can be the consequence of that. And on top of that, new ocular surface symptoms or worsened ocular surface symptoms can be the result of this. Now, how does tear film instability impact the measurements of our refractive preoperative situation? So as you can see here, the tear film instability develops as a result of hyperosmolarity, as shown is the simplified schematic of the TFOS-DUS2 definition of dry eye disease. So hyperosmolarity is the result of epithelial stress and tear film instability because of inflammation on the corneal surface and epithelial damage, which can be shown by staining of the cornea. Now, 70% of the eye's refraction occurs at the ocular surface. Assuming that a patient's vision has been corrected, doesn't have dry eyes, and osmolarity is normal, light focuses, as you can see in this diagram, at the intended focal point. However, if the patient has a more severe degree of dry eye, and as osmolarity becomes increasingly abnormal, the tear film becomes unstable and not uniform across the cornea. Patients often complain that their vision only clears up with blinking and vision degrades between blinks. This is the reason why. Therefore, yet again, taking pre-surgical measurements when the patient has an unstable tear film is putting the patient at risk of a suboptimal result, potentially adding new or worsened symptoms and visual disturbances. So this is what the result is. So how much impact can the tear film instability really have on biometric measurement? So a very nice study was published actually years ago by Alice Epitropoulos in the Journal of Cataract and Refractive Surgery. And she found very, very nice results. She found out that nearly 20% of the eyes with abnormal osmolarity had greater than 1 diopter of difference in keratometry cylinder values between 2 pre-surgical visits. Here you see patients with normal osmolarity plotted in blue and abnormal osmolarity plotted in orange. The measure of osmolarity increases from left to right on this graph. And along the y-axis is the degree of variation in keratometry cylinder values between the two visits. The scale ranges from no variability at the bottom to increasing in variation in keratometry in going to the top. The dots that appear the highest up on this graph are the eyes in which the variability between the two visits was the greatest. Note that those all occurred in patients with abnormal osmolarity, so that is the orange dots on this graph. Now let's examine this group of eyes more closely. We see that all of these dots with greater than 1 diopter variation are orange, meaning they reflect eyes in which abnormal osmolarity was found. How might this finding impact actually the accuracy of IOL power calculation as part of the pre-surgical planning process? The numbers from both visits were used in the IOL calculation and compared. And 10% of the time there was a greater than 0.5 diopter change in calculated IOL power, meaning that the IOL chosen for these patients would have been different depending on which visits measurements were used. Which visit was most accurate? Were either of these visits well accurate? So this exemplifies the need to identify patients with abnormal osmolarity and stabilize the tear film in order to get the most reliable pre-surgical measurements. In addition, it sometimes occurs that asymptomatic patients become symptomatic post-surgically, making them 2020 unhappy with their surgical outcome. This is often the result of abnormal osmolarity that was present but not detected preoperatively. Identifying these patients early on allows for pre-surgical treatment of the ocular surface and for counseling about possible surgical effects on ocular surface symptoms. So this is an example of one of my patients. So on the left-hand side, you see the IOL master measurements pre-treatment of the ocular surface, and on the right-hand side, post-treatment, and you see half a diopter change. And this occurs really in many cases in our office. So make it to your routine that you measure the osmolarity and take care of the ocular surface before even going for IOL calculations. Now, this is the adverse impact of tear film instability on the accuracy of the preoperative results. And that's why the ASCRS now considered osmolarity testing as an essential diagnostic test. It included osmolarity testing in the 2019 preoperative algorithm. How can we test osmolarity in daily practice? I use osmolarity to aid in the early detection of dry eye disease and to track how effective my dry eye treatment is. It helps me to be a better clinician and my patients to be better patients. How do you test it? Seat the patient with their head tilted back, looking upward and away from you. Collect sample from the margin of the lower eyelid as depicted in this picture. Do not pull on the lower eyelid because this will reduce the tear meniscus height and may prevent tear collection. Tear collection should be taken at the lateral, So the tear collection should be taken at the lateral tear lake to avoid inadvertent corneal contact, and the tip should be lowered onto the tear meniscus. Even though positioned on the margin of the eyelid, avoid touching the eye or the globe, as you may hurt the patient and cause excess reflex tearing or scratch the eye. When measuring tear osmolarity, it is important that the concentration of the tear fluid is not compromised prior to the measurement. And therefore, you must always perform the tear lab test first before any other diagnostic examination, such as tonometry, ocular surface staining, Schirmer strip, tear breakup time testing, or other point-of-care laboratory tests, such as MMP9. Even a simple slit lamp examination can cause reflex tearing, which can dilute the tear and falsely lower the concentration of the tear fluid and lower the basal tear osmolarity. The only exception is when topical and/or dilating drops are used. Testing is allowed when a minimum of 15 minutes has passed prior to tear osmolarity testing. You may test patients with contact lenses in their eyes. By doing so, you can tell them if the contact lens is inducing dry eye, which may be causing contact lens intolerance. So what is the conclusion? Can someone again show my next slide? Thank you very much. So what is the conclusion? Tear osmolarity testing has a lot of clinical utility, which we will review in detail throughout this course on clinical education. So first of all, tear osmolarity testing can be used to support or rule out diagnosis of dry eye disease. Secondly, tear film osmolarity data is an essential component of the preoperative workout of surgical patients. Thirdly, osmolarity data can also be used in the preoperative testing to help identify ocular surface issues that would otherwise lead to surprises following surgery if the right lens power is not successful. And treatment response, you can monitor the testing, and you can monitor it in weeks and months, whether until the osmolarity testing is normal. So I thank you very much for your kind attention.
Thank you very much, Erik, for your presentation, but very interesting. And there are already some questions in the audience. So I have a couple of written questions to you. You may have additional some time to answer this probably. So yes. The first question to you is, if an eye clinic hasn't a dry eye department, what would be your recommendation then? How to handle this with this OSD?
Yes, well, you can have simple tools at your disposal, like staining of the cornea with fluorescein or lysamine green. You can also perform a simple, the old Javel keratometry, when you can see the mirrors, the red and the green mirrors. And when patient has unstable tear film, you can see easily that these mirrors will fade out quickly when you're measuring it. So you know that the tear film is unstable and that there's something going on. So first treat the dry eye, then give them omega-3 supplements, maybe punctal plugs, and let the patient come back in 3 to 4 weeks and repeat your measurements. So also when you're measuring the biometry, measure your different biometry, the keratometry and the axial length measurements from visit 1 to visit 2, and when there are any changes in between, so you know that this was due to the tear film instability. So even with simple tests, you can have a very nice idea. But of course, the tear film osmolarity is, as I pointed out in my presentation, was taken into the guidelines of ASCRS in pre-op testing for cataract and ocular surface surgery or refractive laser surgery.
Okay, so now we got the second questions, and this is also looking to the upcoming presentation with the EDOF lenses. And the question is to you, what are your personal tolerance on the osmolarity regarding considering an EDOF lenses to your patients?
Well, as I pointed out, we first measure the osmolarity, and then we do all the other testing. When the osmolarity is not normal, we will give the patient typically omega-3 supplements, also anti-inflammatory drops with preservative-free, and depending when there is not enough, when the tear meniscus is not large enough, we also put punctal plugs. And we let the patient come back to our office 3 to 4 weeks afterwards, and we do the osmolarity testing again. And then you will see in more than 90% of cases that the osmolarity is back to normal or almost back to normal, and then you can proceed. When you have still when you stay in the cornea, when you see still the piquete on the cornea, you have to be more aggressive into your treatment. So we give them vitamin A pomade before going to sleep on top of that, and we let them come back again after 1 month, and we do the testing again. So when the tolerance is actually not that high, also not on osmolarity, because when patients are coming to you for premium IOL surgery and high performance IOL surgery implantation, they pay a lot of money for these lenses and for the surgery. So it's your responsibility as surgeon to give the highest quality to your patients, and you cannot give them without preoperative very good testing, and osmolarity is actually one of my main testing tools I have in my practice to go for that excellent result. My patients are entitled to that excellent result.
Okay, now I would like to ask to the audience, are there any more questions? Then please raise your hand, then you will be unmuted. Or you can again write it in the chat of the Teams. So we just wait for your questions, some minutes. Somebody of the control unit tell me if there are some questions again? Doesn't seem so. So thank you very much again, Dr. Mertens. It was a pleasure to have you here. We would like to have you physically with us, but under these situations, I think this form of webinar is the perfect way.
Yeah.
And
well,
we know that your schedule is very busy, and you will be leaving now the webinar. We thank you very much supporting us with your deep insights.
Thank you very much for your kind invitation, and I hope to meet you soon in person. So, and have a nice continuation of this very interesting initiative. Thank you very much.
Thank you very much. Stay healthy.
Thank you.
Goodbye. Bye-bye. And now it's a pleasure that we can move to the presentation of Dr. Kristof Vandekerckhove. We are really, again, happy that you made it, despite you are really ill. But I hope you are fit enough that you can let us know about your experience of the replacing my monofocal IOL over the last 18 months. Please, Kristof, it's your part. Thank you.
Thank you, Daniel, for the kind invitation, and thank you to the organizers, Medilas Teolab, for giving us the opportunity to be together tonight. You can show my first slide, please. Okay. So I will, in the next half an hour or so, dwell a couple of minutes on the definition and the concept of EDOF lenses, then show you how we do the surgery with EDOF lenses in our clinic, then share with you how we try to position and how we have grown ISOpure within our existing lens portfolio in the clinic. And last but not least, share with you some of the first results of clinical studies we are conducting with ISOpure and other EDOF lenses. So there is monofocal lenses. Monofocal lenses have one distinct focus, and you want to be that focus in the distance, or in some patients that want to read without glasses, the focus is at 40 or 50 centimeters. But for all other distances, the patient needs glasses. On the other hand, there is multifocal lenses. These lenses generate 2, 3, or even 4 foci, allowing to have an unaided vision over the entire range, near, intermediate, and distance. However, this comes at a price, because generating more than one focus means that the patient is confronted all the time with overlapping images, and this leads sometimes to visual disturbances such as halo effects and glare. So really splitting the light in the eye of a patient is sometimes not a good thing. And that's why EDOF lenses have been developed. EDOF lenses have, like monofocal lenses, one focus, but the focus is elongated. And that elongated focus allows for an increased spectacle-free range of vision without the disadvantages of overlapping images like with multifocal lenses. Now, there's a lot of confusion actually on the terminology, and there's also a lot of misclassification. Looking at the green box on the right, there's a lot of EDOF lenses. Actually, most so-called EDOF lenses are not EDOF lenses because they still rely on diffractive technology. And one of the most famous examples is the Symphony lens. The Symphony lens has been launched in 2014, and the company claimed it to be an EDOF lens, a lens with an elongated continuous focus. But that's not really the case. Actually, the Symphony lens is a bifocal lens based on diffractive technology combined with some chromative aberration technology. The same for the Zeiss lens, the Lara lens, and Technis Synergy is a more recent lens. It is an EDOF lens. It has EDOF technology on board, but it has combined it with the older diffractive technology as well. So in all these lenses, there is some degree of multifocality leading to overlapping images and still leading to some extent to visual disturbances. The pure EDOF lenses are based on either one of two principles. The first principle, the pinhole effect. And there's one lens, the IC8 lens, is almost not used in Switzerland. And then the second mechanism is the lens is simply based on spherical aberration. This is actually a refractive system. And in this category falls IsoPure, but also all of the other latest generation EDOF lenses, as we call them: LuxSmart, Synthesis Plus, iHands, Vivity, and Zoe. And there's still a couple of them more. Now, in the clinic, in Vista Alpina, as for all other lenses, we prefer bilateral cataract surgery. So we operate most patients, both eyes, at the same moment, not only to the convenience for the patient and family members, but also especially in the context of premium lenses, in order for the neuro adaptation to kick in faster. And we systematically, in IsoPure and EDOF lenses, we apply a minimum monovision strategy. We have 0.5 diopters of minimum monovision in the non-dominant eye. We include up to 1.5 diopters of astigmatism, but I do try to compensate for the astigmatism with opposing incisions and with limbal relaxing incisions. Isopure is not yet available as a toric lens. Again, as is standard in the clinic, I never use preloaded shooters. We always load our lenses ourselves in an AccuJect shooter. Now, Isopure was a completely new concept, and we've been brainstorming a lot in the beginning how to position Isopure within the existing lens portfolio of the Vistalpina Eye Clinic. And with the team, we've been discussing back and forth, and one possibility would have been to position Isopure as a new standard lens, replacing our monofocal lens, the MicroPure lens, completely. This would have meant that we would have obtained or targeted a very high share of the lens portfolio, and we would have charged the patients a very low price. On the other end of the spectrum, an option would have been to position Isopure as a high-end premium lens next to a trifocal lens in our clinic Fine Vision, and to have simply an alternative to the trifocal. Then we would have charged the patient a much higher price, and consequently the share of the lens would have been much smaller. But in the end, we have opted for an in-between strategy, and we have decided to position Isopure as a modest premium lens. And we thought we would obtain around 30% share of lenses. And actually, we obtained that 30%, and we exceeded that 30% even. And in the next slide, I will show you by how much we exceeded the 30% IOL share. So we started in March 2020. At that time, we had about 90% monofocal lenses and 10 to 15% toric and trifocal lenses. We are very devoted, very interested in trifocal and toric lenses and premium lenses, but we have a very conservative approach, and that's why we only have and had 10 to 15% toric and trifocal lenses. Then we started with Isopure, and very fast, I must say, we obtained that 30%. So after 8 months, 30% of all our lenses were Isopure lenses. But thereafter, it continued to grow. And today, we are at a remarkable 61% of lenses being Isopure. As you can see, today we still have between 10 to 15% toric and trifocal, so that segment has not been touched. And accordingly, the growth of Isopure has gone completely at the expense of our monofocal lenses. We only have 26% of our portfolio being monofocal lenses. So this is a great story. So with or thanks to Isopure, we could grow our premium lens segment from 10% to 74% within less than 2 years, and with happy patients. That's very important. So what are the contributing factors to this success? More than 1,000 Isopure in less than 2 years, the ultra fast takeoff. So first of all, of course, we have a lot of experience in the clinic with MicroPure, which is the monofocal version of Isopure. Basically, these lenses are identical. They share the same geometry. And I was very happy with this lens since 2016. Visual acuity is very good. It's a very refractive, a very precise lens. The position in the back is very stable. I always say that you get a lens and a capsular tension ring for the price of one. And implantation is very smooth. implantation or ease of implantation is a very important factor. And all that was great for MacroPure. So we had a good feeling, a good level of confidence to start with IsoPure. Second, we had discussions with the entire team at many occasions, and we really brainstormed together how to position IsoPure. And we really early on we agreed upon a positioning, and we agreed upon how to inform the patient and what to promise and what not to promise. Third, in order to get a feeling about all the other last generation EDOF lenses, I did small studies with 10 to 20 lenses of each manufacturer, and I could benchmark them on a couple of parameters. One of them, as you see here, one of them being ease of implantation, which again is a very important feature for a new lens, and a lot of new lenses come to the market with a suboptimal ease of implantation. Last but not least, we decided early on to conduct clinical trials within the clinic. If you conduct clinical studies, you're forced to look into more detail, even into more detail, and you gain knowledge and you gain confidence moving on. So we have not only extended the range of focus, but in the meantime we have also extended vastly the range of indications. So we started to test the lens also in patients with comorbidities, where typically a trifocal lens would be a contraindication. So I have implanted IsoPure in patients with mild macular disease, dry eye, with corneal scars, also in patients where we had done retinal surgery, and we really were very satisfied with the results. We could offer these patients an increased range of vision, spectacle free. Then another interesting segment is the segment of post-LASIK patients. So post-LASIK patients, again, this is a segment where you need to be careful with trifocal lenses, because patients are very demanding. They have already undergone surgery to get rid of the glasses, first of all. Second, they have a suboptimal cornea in terms of contrast sensitivity, or this might, with the trifocal lens, this might impact contrast sensitivity even more. And third, post-LASIK, you have an increased risk of landing off target despite all measurements and IOL calculating and tools and algorithms. So we now use IsoPure very often in post-LASIK patients, and with very good results again. Then in patients with amblyopia, another typical contraindication for trifocal lenses, we are using IsoPure, of course not in severe amblyopia, but with moderate amblyopia, you help the patient, you give them some added value compared to simply a monofocal lens. Then we have been experimenting with different target refractions. So instead of targeting 0, we have been targeting -1, -1.25 in patients that are keen on doing all their work, reading, working on the computer without glasses, patients that don't care for wearing glasses, for example, for driving. And indeed, with this target refraction, the patients were very happy. They can do everything, computer and reading without glasses, and for driving, they have a very minor correction of -1 diopter. High myopia, that's another segment. Again, most high myopic patients, they have some macular changes. The postoperative refractive result is also a little bit uncertain. So again, a very tricky zone for trifocal lenses, but with your with the EDOF lens, you can the patient can benefit a lot. And even if, again, in high myopia, you're somewhat off target with your calculations, and the extended focus will give you some spare capacity to absorb that. Mix and match, we've been doing mix and match. Patients that come in with a monofocal lens in one eye, you can still do the second eye. With IsoPure, the patient will perfectly adapt to the situation and will have an enhanced or an increased range of vision. Another situation of mix and match would be a patient keen on having trifocal lenses, and maybe in one eye a trifocal lens can be implanted, and the partner eye, for some comorbidity reason, there might be a contraindication, and then in that partner eye, typically I will implant an EDOF lens, and the EDOF lens in the one eye combined with the trifocal lens in the perfect eye, they do well, and you don't take the risk of severe visual disturbances. And then the last category are the category of the difficult patients where the eye probably perfectly would fit a trifocal lens, but you are afraid of the maybe extended post-surgery chair time, teachers, colleagues, lawyers, mothers-in-law. So why not use an EDOF lens in this case? This is a very good compromise. You still offer to these patients an increased range of vision, and you limit your risk, you limit the risk of increased chair time after surgery. So you can read about all these indications, all these lenses in an article I've written on LinkedIn last year, if you're interested to do so. And now I would like to share some of the results with our clinical studies. We've been conducting a retrospective study in 124 cataract eyes. The follow-up is 3 months. Again, these are patients with undergoing bilateral surgery, minimum vision in all patients, and correction of astigmatism with incisions. Up front, I can tell you right away, the results are reaching our expectations. So the distance vision was very good, and one can say uncompromised. So the distance vision was similar to a distance vision with monofocal lenses, and of course the aim of the lens is the extended range of vision, and the intermediate vision in this study turned out to be very good, and to our surprise also the near vision, although this is not a lens meant to be a lens for reading without correction, also the near vision uncorrected was very good. And last but not least, in the context of premium lenses, always the quality of vision is an important parameter, and there we were again monofocal-like. I will go into more detail in the results now. So this is the defocus curve. The defocus curve is important for EDOF lenses, also for trifocal lenses. The defocus curve clearly shows you shows you the range of defocus where the patient still has a functional good vision, functional vision being defined as 0.6 or above. So as you can see, with a defocus ranging from minus 1.6 diopters to plus 0.8 diopters, we still had a functional good vision of 0.6 and above. This reflects actually good distance vision combined with an intermediate vision up to 63 centimeters. So clearly the intermediate range is well covered, as well as the distance. And in the distance, we have a little bit of, you can call it spare capacity for lenses, for eyes that end up landing a little bit off target. And there you still can compensate with the elongated vision. So if you want to know that in more detail, what this means is if a patient has a postoperative myopia of 0.8 diopters, the visual acuity will still be in functional range above 0.6 diopters, 0.6 decimal. Now, how does that translate into visual acuity? First, we look at best corrected distance visual acuity. This is actually the most important parameter always, especially in the context of premium lenses. You don't want your premium lens to eat away at your best corrected vision. And as you can see, the best corrected vision was 1.1, and also the uncorrected binocular visual acuity was 1.0, despite the fact that one eye had a minimum of vision of minus 0.5 diopters. So the distance vision is really uncompromised. You can say that with a lot of confidence. The intermediate vision, which is of course the objective of this lens, the target, was very good. 0.8 binocular uncorrected intermediate vision. And again, to our surprise, even if not meant to be a reading lens, uncorrected binocular vision was very good, was 0.4. So the promise of extended range of vision was clearly met in our study. But now, are the patients really happy? So we asked about spectacle independence by means of the PRISC questionnaire, and 93% of patients told us they were comfortable without glasses for all activities in the distance. The same for the intermediate range, 93% of patients happy without glasses. And to our surprise, for near activities, including reading, 40% of patients told us they were comfortable without glasses. The third pillar of analysis, of course, is the quality of vision. We have confronted all patients with pictures of glare, halo, and starburst. And 1 month after surgery, these are the results 1 month after surgery, there's a very low percentage of patients reporting these photopic phenomena. These are very low numbers, taking into consideration that we confronted the patient directly with pictures. Second, that we had mini monovision in all patients, because naturally mini monovision increases the probability of halo effects. And third, you need to take into considerations that these are freshly operated patients 1 month after surgery. If you look, for example, in the literature for trifocal lenses, you will typically find that 1 month after surgery, more than 50% of patients are complaining about glare, halo, and starburst. Now, these seem to be very robust study, very reassuring, but still this is a retrospective study. Are we satisfied or do we need something more? Yes, I do think we need something more, because the real deal, ladies and gentlemen, the real deal is always a head-to-head comparison. And we are about to start a direct comparison between IsoPure and the Alcon lens, the Vivity lens. In a prospective way, we will look at all the parameters in 130 cataract eyes. We are working very hard, and we are confident that we will be able to provide you with first data at the ESCRS later this year. Thank you.
Kristof, thank you very much for this very interesting insights in your daily practice and in your experience. Thank you for that. Now I would like to open the discussion and kindly ask the audience to put some questions in the chat function or to raise the hand in the Teams frame. So we give you some time to ask your questions, please. No raised hand, but we have some written questions in there, and it seems that there is a need that you highlight some points that you even already presented in your presentation. The first question already is answered by you, but again, what is the target refraction of the IsoPure recommended by the company or in your experience? What is the best target refraction?
The target refraction in most patients, of course, will be ametropia. Although I think a very good strategy is the strategy as we have adopted to have a mini monovision on the non-dominant eye of minus 0.5 diopters. My study results clearly show that this has no impact on the uncorrected distance vision, neither on halo effects, but you gain a lot. This 0.5 diopters on the non-dominant eye will further increase the near and intermediate visual acuity. And then a third, more rare situation, as I also highlighted, is patients that really are focused more on the near distance. You can simply then go lower and have -1, -1.25 in both eyes. These patients will be reading very fluently, will be working very fluently on the PC, and the only disadvantage is that they will need small correction for driving, like -1.0 diopters.
Okay, now we have a second question that probably is an issue in another practice. So if you have a patient that is already operated in one eye with a monofocal lens, would you consider an EDOF lens and IsoPure in the second eye then?
Okay, I also talk about that. We are confronted very often with that situation, and without any hesitation, we now do implant in the second eye an EDOF lens. Both lenses, they match perfectly together. There's no doubt about that, and you still offer the patient a hell of a lot more as compared to implanting a normal monofocal in the second eye.
And the next question to you, Kristof, is obviously from somebody who is hesitating to present this lens to a patient. How long is, in your experience, the patient chair time for pre-op and post-op consultation compared to a trifocal or compared to a monofocal lens? Is it more or less or even?
I think the preoperative chair time is a little less than for trifocal lenses, simply because you don't need to discuss all these contraindications, side effects, and special situations. So it goes a little bit faster. In terms of preoperative measurements and calculations, we do consider the EDOF patients as a fully premium patient, so he gets the same number of measurements, calculations, etc., as a trifocal patient. Then in the postoperative follow-up of the patient, clearly the follow-up is very easy. It's almost like with a monofocal lens. You won't have a lot of questions. You won't have a lot of dissatisfied patients. Of course, it also depends upon the private price you ask from the patients. We tend to be very moderate in terms of what we ask from the patient, but if you'd, like I've already heard in Switzerland, if you'd ask for 1,200, 1,500 francs per eye, then the expectations of the patients will be very high, and you will be also confronted with a little bit more post-surgery chair time.
Okay, thank you. I have a look to the technique. Is there some more questions in the chat or a raised hand? So please ask your questions, and so there is another question. Could you explain a bit about the patient journey? Who does inform the patient, and who is selling to the patient? So what is your experience in your clinic?
In the clinic, we are not selling anything. We are informing the patients, and right now I must admit we don't have opticians or optometrists involved. It's all done by our physicians, by our ophthalmologists, and they, at the time of cataract, at the time of indication of cataract surgery, they offer the full range of possibilities of possible lenses. We have a full range of lenses in the clinic, and they discuss with the patient all the possibilities. So the patient journey is like for any other cataract patient. And as soon as the patient has decided to go for an EDOF lens, then of course the journey becomes a little bit more complicated. He will undergo many more measurements than a standard cataract case, and this also implies often that the patient has to come back a second time, sometimes a third time, because we really want to have the best measurements possible in terms of topography, biometry. We often have to treat the patient a couple of weeks for dry eye and for lid margin problems. So the journey is a little bit longer and complicated for the patient if he wants to take benefit of EDOF lenses.
Okay, we got the next question from Martin. Does the autorefractometer works with the Isopure with this kind of EDOF lens?
We never had major issues with that. I think it's more tolerant than to trifocal diffractive optical systems. A very important remark, though. You really need to be careful after surgery. If you have the patient in front of you, you don't want, if you do refraction, you don't want to give him too much minus refraction, because his EDOF system will absorb any minus glass you give him. So really start with blurring the patient, start with plus 0.5 diopters and then go all the way down to 0, and if needed go up again. So refrain from putting too much minus in front of the patient, but because this is normal, he will easily absorb up to 1 diopter of minus, leading to the false diagnosis of post-refractive surprise.
We got another question. What is the minimal photoptic pupil size to achieve reasonable near vision? What is your experience?
Again, this lens is not meant to be a lens and should not be proposed to the patient as a lens allowing reading without glasses. I mean, it really depends upon the patient to what extent he will be able to read. And the pupil size, I mean, the lens, you can have a look in the technical details of the lens. The lens is very pupil size independent, contrary to other lenses on the market. It's really not an issue at all.
Okay. So
the intermediate vision will be very much independent on the pupil size or on the surrounding light.
Okay, next question we got looking at the intermediate vision. How do you define for the patient information intermediate vision? Is this computer working, or is this cooking, or what is it?
Yeah, we show the patient different activities. We talk about computer work. We show them pictures of cooking, eating, also interacting with people on a one-to-one basis. There's many more activities in the intermediate range than just computer activity. If they want to see something on a tablet, they will be able, if they don't expect to be reading all the smallest detail on their tablets.
And the next question is, and how sensitive is this lens for decentration?
First of all, the lens will not decenter because it's a very stable lens due to the inverted C haptics, the closed haptics. The lens is extremely stable in the back. I would not recommend, as with any premium lens, I would not recommend to implant a premium or an EDOF lens in an unstable back. If the patient pre-surgery has clear back instability, I would refrain from putting that lens.
Okay, thank you for that. There are at the moment no more questions. Last chance to raise your hand and to ask your question when we will unmute you, but I think this is it. Thank you very much, Kristof, for this really interesting insights to your practice with the EDOF lenses. We wish you all a very fast recovery of your infection, and we hope to see you soon personally at the Congress or in your practice or anywhere else. Thank you very much being here despite you are ill. We didn't recognize you. It was an excellent presentation. Thank you for that.
Bye.
So thank you to all the participants for listening to this webinar. It was a pleasure to have you here. And if you have questions to the IsoPure or the TearLab, you can all the time call Medilas, and we will love to answer your questions. Thank you again to our co-partners TIA Pharma and TearLab supporting us with this webinar. I wish you all a very nice evening. Please stay healthy and hope to see you soon to an apéro in a physical way, in a nice bar. Goodbye, everybody. Thank you very much.